The ALS Learning Series is made possible because of the Gilbert and Jacqueline Fern Foundation, as well as our corporate sponsors, Mitsubishi Tanabe and Biogen. We are leaders in comprehensive ALS care and research. We realize that people living with ALS may feel overwhelmed and unsure of what questions to ask and what to do next. The Les Turner ALS Foundation exists to care for those affected by the disease, guide them to answers, support them and their loved ones, and provide hope through scientific research. Our support services team is comprised of knowledgeable and compassionate nurses and social workers with many years of experience guiding people and their families affected by ALS. We provide care visits by ALS support services coordinators, and we offer support group meetings, educational materials and programs, access to medical equipment and communication devices. We provide need-based grants and in-service education to the community. At the Lois and Salia ALS Clinic at the Les Turner ALS Center, we offer access to enrollment in clinical trials and dedicated clinical trial coordinators. We are Chicagoland's first and largest multidisciplinary ALS clinic with the highest number of neurologists and dedicated pulmonologists. We provide multidisciplinary care, that brings together an experienced team of neuromuscular specialists in one clinic to provide comprehensive support to you and your family. And you'll have access to no-cost, coordinated support and expertise from ALS support services coordinators from the Les Turner ALS Foundation. It's my pleasure to introduce to you Dr. Colin Franz, tell you a little bit about him. He's the director of the Regenerative Neurorehabilitation Laboratory, as well as a neuromuscular medicine fellowship trained physiatrist based out of the Shirley Ryan Ability Lab and Northwestern University. Dr. Franz has specialized expertise in neuromuscular medicine, rehabilitation, gene therapy, and disease modeling with induced pluripotent stem cells. Clinically, Dr. Franz sees patients with nerve injuries, neuromuscular diseases including ALS, as well as performs neurophysiology diagnostic tests. The Franz lab uses a combination of molecular, bioengineering, and electrophysiological techniques to study neurotrauma, axon regeneration, and motor neuron disease with a priority on human stem cell derived neuron tissue culture and translational studies. The ultimate goal is to develop personalized rehabilitation medicine treatments to help his patients with neuromuscular disease. Dr. Franz is a member of the Lois and Salia ALS Clinic, part of the Les Turner ALS Center at Northwestern Medicine. It's my pleasure to introduce Dr. Colin Franz.
Thank you very much. And I will just get my screen up here. All right. We'll get right into it. I know it's 10 past the hour, so I want to make sure we get to the talk, and I'd like to be able to just encourage people if they have any comments or questions to put them in the chat, and we'll get to them towards the end of the talk. I have no disclosures or conflict of interest to disclose. Today's talk will go through some general pointers that actually this is sort of something that started as a bit of a thing I introduced people to my research team in terms of how to approach research articles for our laboratory and research program, but also some work we've also done in terms of engagement with the ALS community to help people become more informed or consumers of research information that we are constantly monitoring for breakthroughs and advances related to ALS. And I will tell you a little bit about how to look at the authors and what journal papers are published in, break down the sections or where sort of quote unquote dissect the parts of a paper, including the quality of the study. And there will be a little bit of an adapted small group exercise in the sense that I'll take you through an example of how we can put these tools I'm going to teach you today to use. So overall, if anyone, I think it's only natural for pals and their family members and friends to want to read the latest research and see what's going on. So my advice is generally when you get a research paper, to sit down, the natural thing for any of us to do is read the summary. So read the abstract, what's called the abstract of the paper. But don't stop reading there. Continue reading, because that tells you what you're about to read, but it's not always, it's lacking some of the key information that I think in order for you to understand what was done and, evaluate the quality of the paper. My advice to everyone reading a paper, just write down your questions, write down comments as you read it. It helps you be more active in your reading and pay attention, which is probably a good tip just for anyone reading for school or any reason to help retain the information, but also so that you're thinking about what you're and actively engaging what you're reading, and not just sort of zoning out and just taking too much the guided tour of the paper. And if the paper isn't clear, which is often a feeling I get even when my research team is presenting articles, in terms of the way the science is presented, why they're doing things, don't necessarily always beat yourself or assume you just can't understand it because you don't know enough. It's not always, there's a very big responsibility on the people writing the science to make it consumable to the audience reading it. So I will add the other thing about being in this, and certainly with decades of clinical trial work in ALS, only a few things that have really come through with FDA approval, that resist the urge to be too pessimistic. And I thought I had coined a term when I was thinking about this presentation about being skeptical optimist. And then I quickly realized by Googling it that I wasn't the first person to think of that term. And, for example, I found this website here with a story called Be a Skeptical Optimist, but I think it's a nice description of an attitude to take towards consuming this information, because there's sort of in the continuum of being skeptical and being pessimistic versus being optimistic. I think what I would advise most people to do is sort of try to situate themselves, not necessarily way out here in the top right corner, but probably living right around here. Approach something with open mind and with some optimism. And obviously there's been disappointments in research and in science in a lot of different neurodegenerative diseases, including ALS. But it doesn't mean that the next big trial, the next study is going to necessarily fall short of its mark. But so we got to strike the right balance. And don't be afraid. I think when you're reading papers for the first time on your own, you may, not have the formal scientific training to feel comfortable taking in that information all by yourself just on the first try. So who are your different resources? Of course, you may have a friend or someone who can, with some experience, like a family member who could help you through it, but also feel free to come to clinic, talk to the people around you. There's a picture of me, but I surrounded myself with people in clinic and in this particular expert panel at the Les Turner Foundation annual symposium that we do in the fall, with people like, Dr. Driss, who's our clinic director and a neurologist and a mentor to me. People like Dr. Wolf, one of our pulmonologists who's constantly out there presenting and sharing information with the ALS community across the country. And of course, other colleagues. It's a small group of us who work in these specialty clinics. So I often, take my own advice about asking for help and reach out to people like Dr. Pagione, who's a physiatrist and a neuromuscular specialist at Harvard and MGH. And then don't forget about, with the Les Turner group, we have so much expertise. This is a picture I found on their Facebook page, but this is Julie Stowell, and they're running a support group. And I blurred out the people's photos, even though it was on the website, just since they didn't have their permission to use it. But there's a lot of people that we're all very willing, I think, to answer questions and try to help people be more engaged in what's happening in ALS. So back to my point. So looking at the paper first, one of the first things I do when you look at a paper, you look at the title page, like who wrote the paper, what's the title, and what journal or is it published in. So who are the authors? And this is just sort of a joke, because sometimes it says you should spend the next week typing down the names of all the co-authors of your papers, but you can see sometimes these extremely enormous lists of all authors from different universities that have participated in the study. And there is a tendency to like, well, what's the important bits of that? Well, knowing where they're from, what countries they're from, where the trial was run, could definitely impact whether or not where the therapy that's being studied is going to be approved or apply for regulatory approval. And there also can be impacts. For example, I use the example of a clinical trial that was run exclusively in Japan, which comes to mind as the Darabone or the Radicava trial, which had very specific rules that had to follow with its design. That might not be the same rules that for a trial undergoing investigation in the United States. Having a longer list of authors may also, usually implies that there's multiple sites involved. So there's patients and clinicians and populations that are represented in more geographically diverse regions than just one single center may have a very specific makeup in terms of who it serves, and that can be worth noting. Also, at the very end of a paper, there's usually a section where you can list your conflicts of interest, and particularly if members from a company are on the author list, you might want to look into that in terms of keeping that in mind with how you digest the information. And then also, one of the natural things to do is look at the authors list and see, well, have they published other papers? Where are the other papers or other clinical trials, ones that are particularly remarkable? Is this the first paper on an ALS subject? And also, when you're looking in that title page, so what journal is it published in? And this is a cartoon sort of with the centerpiece of it being impact factor, which is a metric that has flaws, but is something that we still, even as researchers and clinicians, look at a lot, which is a reflection of how often papers from that journal are published, are cited by other journals. And so it is a bit of a metric to get a sense of the quality of a journal. It's not perfect, but this is beyond our kind of focus to kind of get into that, but it's usually listed on the journal website. If you just do a quick search, you can usually get their most recent impact factor, and higher numbers are better, with the caveats I add. So the other thing is, so if you're going to check out the journal, because some of the journals, like the New England Journal of Medicine, is obviously world-renowned and one of the best places you could have your paper accepted based on reputation. And then there'll be the possibility that you have a journal that you've never quite heard of. And there's been an explosion in the number of journals out there. One of the key things about any place that you consume information from is it peer-reviewed? Does it describe, and you go to the website, is there a description of peer review process? Is it indexed on the PubMed search engine, which is freely available for you to search? Not the articles aren't always freely available, but you can at least see that the articles populate in that search engine. It's a bit of a red flag if the things are not coming up on the PubMed search engine, but it does not guarantee quality just because it's searchable in that index. I said the impact of the journal, and then often, like I used the example of the New England Journal of Medicine, which publishes papers on all sorts of breakthroughs throughout medicine, not just in neurology or neuromuscular medicine or ALS. And then you get a sense of, is this published in a particular niche journal for with maybe a less broader audience or scope of interest, or is it something that is such a big breakthrough that maybe it's available for the, in a general journal like the New England Journal that we think would be broadly relevant and is to the entire medical community, which roughly correlates, I think, with the magnitude of the results. And now dissecting the paper. So what is the anatomy of a research paper? I use this analogy of dissecting or looking at the anatomy, and I'll take you through the different sections of the paper and how you might think about them in terms of how it could, like the analogy of the human body. So the most superficial part of our body, the thing that everyone sees first, is our skin. And I sort of make the analogy that that's sort of like you look at the title of the abstract, maybe the introduction section of a paper, as being that superficial bit. It's going to set you up for the next things in the paper, but it's the first thing you see, it's the first thing you can consume, and sometimes in some cases more than others, it can be kind of flashy in terms of trying to get your attention. And we'll dive into each section a little bit more in a second. The methods of the paper, the design is essentially the structure, the backbone, and the foundation for how solid the paper could be. Because if the design is flawed, then everything that flows from that flawed design is going to have its big limitations or caveats. Although most papers do have some limitations, even a well-designed study. The data, the results, and the figures, with the tables that you see, those are what really make the paper go. So that's why I lumped them together as the nervous system. These are all the nerves in the brain, and the heart and circulation, because those are the things that I think are really the most important substance of any paper. And then lastly, the discussion conclusions, it's kind of not the spin, because it's unfair to say that every paper has a lot of spin in it, but it is a section that can be spun a little bit in terms of how you interpret your own results by the authors and the claims that they make. So that we have like the airway, which of course the lungs are, if you ask Dr. Wolf or Dr. Coleman, the most important, one of the most important parts of the body, but it's also where you can kind of blow a little bit of hot air, and I won't really bother with the joke you could make about the digestive tract, but that part of it, it's very important. But in terms of the hierarchy, I think a lot of physicians, a lot of scientists really want to see these data, like what is the data, and make sure that there's good design. Those are the sections that we spend a lot of time on, but they can be sometimes the hardest ones to get through. So we'll talk a little bit about what things you need to pay attention to for those, and as it pertains to the quality of the study. And I wish it was as easy as these two pictures to figure out the high quality versus the low quality research paper, but it can actually be very difficult if you're not used to be thinking critically about these things. And when you think about it, let's break it down by the different sections. So the introduction, I mean, it's really critical, both for the standpoint of writing papers, when I'm trying to teach people in my research lab how to write their own science up, but also for the purposes of consuming it, so that you understand why something was done. And so do they explain, is the problem explained right off the top, and really setting up why, when you're consuming a research study, why they went ahead and did what they did. That's essential, and you should write that down as like I said, write the notes as you go down, but write down, okay, so they wanted to study compound A because compound A can block enzyme B, and then enzyme B is linked at high levels, is linked to motor neuron degeneration and ALS. Okay, I followed the thinking here, and you've got me. But it's often not easy to follow a poorly written paper's logic, and that can be a bit of a red flag. And also, one of the things I look for most of the research studies I look at is, do they have a hypothesis, and do they tell you the hypothesis? Usually, most studies will have a hypothesis, but it is surprising sometimes to me that they don't indicate, what they're trying to test here, other than in some research studies that basic sort of element is missing. And in some cases, one of the things that needs to be clear when you're looking at different phases of research is maybe that you think that the outcome would be for an ALS study to protect against the ALS or to slow the disease. And sometimes it's just to look at the hypothesis is that this drug is going to reduce a biomarker or protein of some sort, or something that you can test in the body, the blood, the spinal fluid. So being clear on that really helps you understand what the goals of the study are. Next part of thinking about the quality, let's go into that methods section, which I use the analogy of being the skeleton or the foundation for the study. And one of the things when you're looking at the study that I thought to point out, because it's going to come up with some of our examples, is what was the primary outcome that they were testing? And I know it sounds, it may not sound that important at first, because often studies measure lots of different things in terms of, if you take this compound, we're going to measure your muscle strength, your endurance, we're going to measure your breathing, et cetera, but you have to, when you're doing a clinical trial, you need to declare one outcome as your main outcome to prove whether or not something's successful or not. And that's partly to avoid this issue of where if someone has 40 outcomes and we use statistics to kind of prove whether or not there's a difference in each of those parameters, and then you, in retrospect, decide to pick one of the outcomes that wasn't obvious for why you would have picked it as your main one, but other than the fact that it was the one that showed a difference. And that kind of cheating, because the more times you run statistical tests, the more times you're likely to have just a false positive result where you conclude that something worked when it doesn't. And so that's why it's so important that people declare that. And that's not a very in-depth explanation of the statistics, but it kind of gets at one of the reasons why we think that's so important, even though it can be frustrating with some recent trials too, where the primary outcome was missed, but maybe some other secondary outcomes showed some more reason for hope. So do they clearly explain what they did? I mean, I mentioned this over and over again, how well they explain what they did, their logic, their flow of thoughts, as well as the fact that you should be able to, if you write notes and follow along, understand what is the flow of logic. I mean, that's important, not just because it allows us to understand, but if you can't communicate that, it creates issues around, well, how well thought out was this to begin with? So the other things that create issues about reproducibility is, are they really clear about what their intervention was and the dosing? For example, if you had a vitamin that they used in the study and you had access to it, would you be able to figure out how much to take? Is it described at that level? Did they register the study with the clinicaltrials.gov website, which is a great resource if you haven't checked that out, because you can look, amongst other things, trials that are going on in your area, those that are actively recruiting, and the type of trials and your eligibility for them. But also it allows us to know, for example, what the primary outcome was of a trial prospectively, so that it's all written down so that people can then see it for themselves. And then when the trial reports, you know that everything's been sort of, all the boxes are ticked for the quality when you go back and make sure that that was the primary outcome, is what they said it was going to be, etc. And a lot of journals will only take clinical trials now that have pre-registered or been registered in clinicaltrials.gov. So it's definitely a great resource for people to know about. So who was included in the study? Who was excluded? I think for a person with ALS reading a paper, you might want to look at how those sorts of criteria might even compare to themselves, because with any research, although we can generalize research beyond the population being studied, if the population being studied had very strict rules about who's in and who's out, it's sometimes done for reasons that we'll come up with that helps us get to the answer a bit quicker with ALS studies, but it may also mean that the information that you derive from that trial may not apply to every ALS patient. Did they use controls? Did they have a placebo? Was there any blinding? I mean, these are things that are necessary for some scientific rigor, but we also feel like a pretty torn about because we want to minimize the use of people in trials who don't get an active treatment, and for the duration of time that they don't get the treatment, and then whether or not they're offered the opportunity to get the treatment at the completion of the trial, because you're participating in research that that we don't want you to be doing it all without the opportunity to potentially benefit. But it is research, remember that too. So we don't actually know if things work, and we don't want to be fooled or give people the wrong information at the end of it. So that information, along with reporting of safety events, is really critical, so that as a doctor, I mean, the last thing we want to do is make a recommendation for someone to take a therapy, and then for that therapy to actually not only not help someone, but to hurt them. So here's an example about methodology in inclusion exclusion that I took from the Edaravone clinical trial, or you may know it as Radicava. And there were actually 3 trials on Radicava. The third one was the one that showed the slowing of progression of the disease, which is, if you look here, this is the ALS FRS. It's a functional rating scale, and the change in that over time, if it goes down more, it means that the disease has progressed more. And so over a 6-month period of time, they're looking at this change in slope of this curve, because we expect it to go down through the natural progression of the disease in people with ALS. And you can see that if you have the treatment here in the orange line versus the blue or the teal line that had basically the sugar pill, or the in this case the infusion, you can see that that the decline is less. And what I point out is that while we saw this with this trial here that was published in the Lancet in 2017, which led to this drug's approval, the earlier groups studies had not shown this difference. And based on the analysis after the fact, there was a possibility raised that only the people who were started on the drug who were less affected by the ALS were benefiting, and or benefiting the most. And that's why they went back and redesigned the study this way. So that does leave us with the possibility, although there's more information coming out now on how Edaravone might be useful for other groups of people who weren't in the initial included in that positive study that was published in Lancet. But this sort of tight inclusion criteria, exclusion criteria, is a double-edged sword, because it's great maybe to get an answer for your clinical trial, but does affect how we generalize it or how we advise people who come to our clinics who might not fit that profile perfectly in order to match the people who benefited from it in the study. And particularly when the study prior to that didn't work, when it had more open inclusion criteria. So that's something to think about. What's the quality of the results of the figures? So one of the things I tell people in my lab is when you're presenting a research article to us or we're discussing it, I don't know if you've ever looked at a paper, but sometimes you're looking at the graph and then you're looking at the description and then the graph and the description, and you're going back and forth and trying to put your own labels on it so you understand what they did. And really, well-presented science should be easier to consume than that. But I mean, it's not the only thing that matters, but is it clearly presented? Is there sometimes it's just an honest, so, oh, well, I guess we could have labeled that better, because the scientists are looking at the results all the time, so it's hard for them to know sometimes what it's like to look at it for the first time. And then sometimes things are confusing and you wonder if maybe people are just being a little bit less than transparent with the results. And don't, like I said, don't blame yourself. I mean, that you're the consumer. You're not all, it's not like the customer is always right here, but the data is supposed to be presented in a way that makes it easy for people to understand. And I know that the other thing, if you keep track, is I told you to keep track of what's the primary outcome. And then when you're looking at the results, since that is the thing that the author said that they wanted to be measured on, and we know that it prevents, by declaring this, it prevents the problem of people sort of changing the question to match the answers that they got a little bit in retrospect. So by declaring that and understanding whether or not that changed, it's one of the first things you should be looking at when you read the results section is was that affected in the direction that we were hoping for. And then the other thing, I guess, from a practical standpoint is, okay, they say that this is helping. So is this intervention slowing the progression of the disease? Did it halt it? Or is there a reversal where you're actually seeing improvements? I think this latter condition, which is what we really are aiming for, hope, like something that not only treats the disease, but actually gets back function. I mean, that is the thing one of the things that we're missing right now in our ability to treat patients with ALS. So that is such an important thing, to keep in perspective. But slowing is, what we've achieved with Rizal and with the Darabone. And that's not to say that's not meaningful, but, think about that in terms of how the data is presented. Because I think sometimes there's this disconnect. Is this a cure for ALS, or is this something that can slow or just treat ALS? And, it's just about sort of processing, like, what is the true impact of this, of these results, these positive results? Because, just a positive study doesn't necessarily mean that we have a cure, whether it's in an animal or in a clinical trial. And then I use the example of the brainstorm results that were announced in the late 2020, where the primary outcome in that case did not meet the statistical significance, which was the reduction in the progression of the ALS based on the FRS score. And they were looking for a certain percentage of the people not to progress a certain amount based on that scale. But then as you read further down, and to declare, this is the press release from the company, but there may be a meaningful response compared to placebo in a pre-specified group of people. And I'll show you what that kind of means based on, although this trial isn't fully available, all the data for us to look at from the phase 3, the phase 2 data from Neurone is available. That was published in Neurology in 2019. And what they're talking about in this change in the ALS FRS, which is like the functional rating scale that I mentioned, and that it goes down with time. We know that as the disease naturally progresses. So if we change the slope, or we slow it, and this is sort of a way of plotting that in terms of it being better for you to be going upward direction than going the downward direction in terms of your slope. That with the people in blue who got the actual cells, with Neurone is one of the mesenchymal stem cell therapy that's injected in the spinal fluid, versus a placebo where they inject just a solution that's not the stem cell, not the cells into the spinal fluid. You can see that while there's no significant difference between the two groups, when they break out just the subset of the faster progressing patients with ALS in the two groups, so this subset suggests that there was maybe a little bit of a benefit in terms of slowing progression in that specific group of people. That was from phase 2, and for phase 3, we're waiting to fully analyze, for the full reveal of all the data. But this is potentially speaks to the importance of understanding both the results and how to take in the results about these subgroups, but also, again, the inclusion exclusion criteria. And then if it has to be given to those people to see the benefit, how much do those people look like me or my loved one with ALS, and they're, in terms of trying to understand what the meaning of that is clinically or to my life if I was to get that therapy. And finally, the discussion and conclusion section, which I sort of compared to but it's kind of the area where we integrate with what's been done before, and then sort of make the summary of what our actual results were, in terms of like the big picture. And does the data that they present in the results section, does it match the claims in their discussion? Sometimes people have a tendency to go right to the conclusions of a study instead of reading the results. I can't blame them. It's a little bit faster to get through the information, but it wouldn't allow you to make that sort of check for congruence between the data and the conclusions. So, and like I said, conclusions are, I'm not to be too pessimistic and violate my rule, but sometimes there is a little bit of hot air being blown there, so be careful. How does this fit with what was done before? Is there a disagreement with a prior study? Is there like conflicting results now between the new study and the old study? This should be discussed, and explanations should be proposed or presented in the discussion, so that can be helpful, particularly when there's like an area of great controversy. And then finally, it's always important that, because every study design has certain limitations, and particularly in ALS, where it's not like we're testing out a blood pressure medication and we can test it in thousands of people in the time frame of just a year or something. We need to test it out in the numbers that we can recruit in order to answer the question, but we're sometimes constrained a bit more by with some of these studies that look promising, or early phase studies that are designed at either like a pilot level, where we're just trying to get a clue about how we might do the feasibility of a larger trial. That could give us a signal, but is also more likely to have like false positive or false negative and these sorts of issues. So any really fair, I think, discussion of your results should at least acknowledge that no study is perfect, and what needs to be done in the future, what could be done better. And it's concerning when there's no limitations listed in that paper. So let's take an example of this recent trial on the drug medication, which it's a bit of a mouthful, the sodium phenylbutyrate diol, or easier to say, I guess, but not necessarily catchier, AMX0035. But it was published this year, this past year in the New England Journal. And then there's been some subsequent papers that have come out on it with longer term outcomes. But what I'll point out is that if you look at their results here, with their primary outcome being the ALS-FRS scale, which tends to be a very common outcome measure. So that's something you'll see a lot if you're reading ALS papers. And you can see that the decline in that scale per month was less, that number smaller in the drug group than in the placebo group, minus 1.24 points versus minus 1.66 points on average. And statistically, that comes out, the p-value, which is, we're looking for usually numbers that are less than 0.05 to call it statistically significant. So it comes out just slightly below that, but supporting that this difference is not due to chance, and that this is really a real difference, real slowing of the disease. So that's the results. It's not, when you look at the magnitude, it's 1.2 to 1.6 approximately. So it's not a cure. And they don't try to claim that it is. So when you read the discussion, I think it's a pretty fair analysis. I just copied the section in where they point out a couple things. In our trial, treatment with this drug slowed the decline in the ALS functional rating scale over a 24-week period. But they point out that their secondary outcomes were not significant, which is true if you go through the table. But the people in the drug were also more likely than the people who got the placebo to discontinue the regimen because of adverse events, which were generally gastrointestinal adverse events, so stomach, GI issues. And then they point out another thing that's needed in the future is that longer and larger trials are necessary to evaluate this drug in people with ALS. And so I think that this is a pretty reasonable and measured analysis of your own results, which is what you're asked to do when you write a discussion of your paper. But acknowledging some limitations and areas for, some to keep an eye on in terms of the safety and what needs to be the next. And so, and I will point out there has been a follow-up study, but this was the first one out in the New England Journal, and there was more to be said about this, but nevertheless, this was an example. I thought something that was a pretty well done job in terms of writing that and integrating that. So, in summary, here, it's important to have our approach to reading your scientific paper about ALS and an ALS clinical trial paper. Be aware of who wrote and published the study. Take a look at the source of the information. Like I pointed out, is it on PubMed? Who are the authors? Are they working for a company that has a conflict of interest? Do they declare their conflict of interest? Always write down your questions and concerns. If at the very least, you can take them to your next interdisciplinary visit to an ALS center and ask your doctor there about them. Or you can send them a message in advance of the visit, which is what I like. Say, hey, I read this paper. Want to get your thoughts when I come in next time. And it's okay to ask your ALS specialist. Now, I'm not saying that everyone that you'll come into contact with in an ALS clinic will talk about, the papers as easily or as often, or with the enthusiasm that you have. But this is like part of the job, which is, we have this disease. We need better treatments. We need more research into it. And we need to also engage with patients and answer your questions about the studies from our perspective. Some of us, we do research actively too, can talk about it a bit from wearing that hat, and some of us can talk a bit more about it from the clinical standpoint and other perspectives that we have. And then the only way you're going to get better at reading papers about ALS research is by practicing and doing more of it. So you got to stick with it. The first time it's not going to be as easy as the 10th time, but you just need to have some an approach and keep doing it. So let's try to practice one together here. And I don't think this will take too long, and I know we have looking at the time, so I'd like to finish hopefully in about 5 or 7 minutes. So we have 5 minutes for questions. So this paper I picked on stem cell transplantation into the frontal motor cortex in ALS patients that came out back in 2009. I picked it in part because we recently did a workshop that was co-sponsored through the Les Turner Foundation as well as Neil's and this ALS Clinical Research Learning Institute that they have, which is an interesting program and I think a worthwhile program for people to learn about how to, for both people with ALS or people who are who have an interest because of being affected by the disease, they want to learn more about being involved with ALS research and spreading and sharing good information with peers and so forth about it. And so we call it a research ambassador. And so we covered this paper. So I'm picking that one not to be too nasty to those people, but it is one that I recently led a group on in, for when I participated in this for a group out of Chicago when they came. And so first thing I told you to do was, okay, like this is your executive summary. The thing that you start with is the abstract. And really, I know we can't read this whole thing here with the format. In a small group exercise, we would have read it in advance and discussed it in a different way. But I'll point out that this paper, you just jump to the conclusion of the last sentence of the abstract. And it's a stem cell transplantation in the motor cortex delays ALS progression and improves quality of life. So that is a big claim. It's not that measured. It's an eye-catching claim, and you certainly put that at the end of your paper, at the end of your abstract, and you get people's attention. So that is for sure. And then remind myself too, not, you hear that, you're like, oh, really? I'm not sure that would be pretty amazing if that's true, but it's one of the things where you're kind of like, I need to do a little bit more reading and a little bit more digging. So who were the authors? Well, and where's it published? So who are the authors? Like I said, how this could impact the study, and starting with the author list. So we look at this group. Then I started, well, this is just me breaking it down for you. I said, well, who's the lead author, the corresponding author? And sometimes the first person, sometimes it's the last person. In this case, the person who was listed as corresponding, so the person who you'd reach out to for information, was the first author. So we sort of make note of that, and we'll come back to that in a second. They do declare, it's all from one site there in Monterrey, Mexico, the conflicts of interest. They have a nice section at the end of the paper saying there was no conflict of interest, so that checks out. And this is my little tip on how to sort of stalk people, a bit, just to figure out who they are, because how some people, I guess you might recognize, but a lot of people who publish papers we would not. And so you can go to the university profiles that they're associated with, or their hospital. If they're with a company, you can go to that website, or social media is becoming a better place to find people and get information about them and their views and what they've done. And then this website, in this case, was really good. And I have a profile there too called ResearchGate. It's kind of like and maybe like LinkedIn for geeky scientists and so forth, which isn't to say that it's like the coolest place to spend all your time, but sometimes you get some good information about people there. And you can join. So I clicked on this person's profile, and you get this information about who they are, their credentials. You can see things like the papers they published. I'm not trying to pick on Dr. Martinez here or anything like that, but he's got a paper about brain-computer interfacing, about aneurysms, and about COVID-19 recently. But you actually can click. It's kind of interesting for people who do participate in it, because you can actually look at their projects. And one of his projects listed as 3 projects: a stem cell transplant and ALS. So it kind of checks out. This seems to be a big part of what he does. And he's certainly been active in publishing lots of papers. And you go down his list, you can see a number of papers in ALS. So he's not someone who's just dabbling in ALS. He's pretty invested in regenerative medicine and ALS. And that's as far as I took that. And then in terms of what the journal is, and is it in a good location and so forth, I looked at this journal and I went to the website. It's affiliated with a reputable publisher. It has an impact factor 4.2, which is fine. It's fine. It's not the highest. I think New England Journal is 50 or something, or whatever it is, but it's fine. And I noticed it was the official journal of the International Society for Cell and Gene Therapy, which you click on, and there seems to be a pretty with some sort of relevant affiliation. So it's not one of these scam journals that is just trying to trick people and into kind of fee for publishing, where they publish anything as long as you pay them. So again, I think reasonable to approach this paper with some optimism, not overly skeptical, and looking at it. And I understand that you didn't get a chance to read it, so I'll just point out that some of the key things, because the big statements, the claims that are being made is how many people were enrolled, and it looked like when I went through it, there was 23 patients. So it's it's on a pilot study, kind of very small group of people, but it's how some science and discovery begins. How long was the trial? It was 1 year that they followed the patients. So it's a good amount of time. You saw some of those other trials that we showed you earlier were 6 months follow-up, and at least in what they initially presented. Was there a placebo group or sugar pill or sham surgery? No, people either got it or they didn't get it, and the people who didn't get it knew they weren't getting the surgery or the injection. And was the study blinded, which is again some of the quality sort of control things that you want to look at. So did the investigators know who was getting the treatment and who was in the control group when they were doing the evaluations? And the study was not indicated that it was blinded, so that they would have known that. So there can be sometimes a little bit of an issue around that in terms of what your expectation is when someone comes in after they get the surgery and the treatment versus and you know that in terms of being the assessor. And how did they measure the safety and the efficacy of the treatment? And one of the things that was important here because I told you it was important to look at safety reports, is that they actually didn't present any data or specifically spoke to their plan for assessing safety outcomes in terms of any complications afterwards, other than they did mention one person who died shortly after the surgery, but they didn't really tell us people have headaches, did they have any infections and these sorts of things. And then the efficacy was measured using some of the typical tools, including the functional rating scale. So there was no big problem with using those tools to measure the efficacy. But there was some concerns about the plan for measuring and monitoring safety. So when I told you it wasn't blinded or randomized, in fact, if you look more clearly, that they actually mentioned that the investigator at that site made the decision on whether or not someone was in the cell therapy group or in the control, and so it was not random at all. And the people who were controls were self-selected because they didn't want to have the cell therapy. And so I guess with everything what I'm saying so far is that we know that this is a risk for some bias in terms of who's accepting the treatment, who's not accepting the treatment, and the difference between those people just in terms of just their characteristics. And that could put the risk for comparing, I guess, apples and oranges, so to speak. So the duration of the time of the patients who were in the two groups, when you look at because of the way that they put them in the groups, there was actually people who were in the treatment group had ALS for longer, 30 months, compared to the control group who only had ALS for 14 months, which is notable. There were other differences in the groups, like in terms of the functional rating, so the level of function at the beginning. The control group had a higher level of function than the treatment group at the beginning of the study. And so again, the possibility that there are like just key differences in between the two groups of people, that the control group may not be a representative of the people who received the treatment. And then the safety, I did point out that one person died shortly after the surgery. So, small numbers, but that 1 out of 10, 10%, but we really don't know in larger numbers what that actual risk would be, but it's pretty notable to have an event like that. So what could have been better in this trial that I just told you about? Well, a placebo design of some sort would be better scientifically. Blinding for sure is important to get a more objective assessments that free of bias. Random assignments of treatment, again, to mitigate the effects of bias that could affect our results. Making sure that there's a plan to collect safety data, which is so important when we're running any clinical trial. Even like I pointed out with the AMX drug, that more people discontinue because of GI issues. It's important to know that so we can have conversations in a very open and honest way with our patients when with trial data. And then also having more information about the trial conduct and whether or not there was any deviations from protocols. But I think the overall thing is when you see this information now, you see that there's this big claim, but you also see that there's these limitations with the study that you really have to be careful. So to take it with a grain of salt, it may be a bit of an understatement, but it's certainly have to be careful. So again, I know I took up a little bit more, it's almost 1 here, but I'll say this: the more you try to read research papers, the better you'll get at it. You need to have an approach, and I hope I gave you some tools to help you with that, because I think it's such an important thing to be engaged if you want to read research to know how to do it. And again, I won't say anything more other than thank you. And we have questions time for one question or two in the chat, I would be delighted to stay on. And I know that we're up against the clock here.
Thank you, Dr. Franz. Actually, it's completely fine. I found that to be unbelievably helpful as someone who had to read research articles in graduate school. So thank you really for breaking down the process and steps for us. We only have a couple of questions right now. And I wanted to know on the first one, I wanted to know if you could expand upon it even more than what I can share with the person that asked the question is, what is the role of ALS Untangled for the ALS community? And we know that members of the North American ALS Research Group review alternative off-label treatments with the goal of helping people make more informed decisions about them. So did you want to expand upon that at all? Is there anything else that you might want to say?
Right. Well, I think ALS Untangled as far as a source, I mean, what it is it's an initiative that some of our colleagues and people that I think are of good reputation have tried to make available that breaks down some of the data that exists on different approaches to treating ALS that you may have read about. It has an ever-growing amount of information on the website. It's not the same as, for example, the opinions there may not be shared by the FDA or the doctors that at your clinic, but I think it's a really useful collection of information that tries to, I think looking at, for example, one of the examples I was thinking about talking about today was an older trial on vitamin E, which people may or may not know was offered to Lou Gehrig himself. And there was a potential back in the 40s when this was being done that there were some ALS reversals with that. And of course, when I think about ALS reversals, Dr. Bedlock, who's involved with the Curly initiative, has an area of interest there, and he's involved with the the ALS Untangled. So I did think about going there, but I know that there's still more work going on in vitamin E. I decided to go a different way, but so I myself will go to its website, and particularly it's nice because you can, for me, not necessarily looking just at their opinion, but also at their sources of information. So I can pull up those. I actually pulled a few of the papers from the 40s, which tend to be harder to find. But someone there, spent the time to have all the references available because they're not easy to search on the web search engines like PubMed or just Google searches because you'll miss those papers. So I have to say though that there's a need. I think that's why I think I emphasize the point to bring the information to clinic or to share it through. In our case, you can send messages through the portal and to prepare for a discussion about a paper or topic related to research in clinic. And I think that's often something I'm willing to engage in. I think a lot of my colleagues spend a lot of time trying to make sense of. But yeah, I can tell you that there's a lot of other sources of information out there that you need to take with a grain of salt. But ALS Untangled, I have found that to be myself a pretty useful resource.
Excellent. And if people want to learn more, they can go to alsuntangled.com. The second question that we received is, what subject numbers, the N, do you look for in ALS trials?
Yeah. Well, I think it's not as simple as just the number. So, you can get an impression, like a study that has 200 patients versus 20. A lot of the trials you'll see, they have numbers in the 100 to 200 range, but it actually depends on a few things. So first thing you're supposed to do as a scientist is say, what's my treatment effect size? So if my treatment, and you might do a pilot study like the one that we looked at, could be just to determine how big is the effect of putting these stem cells in the motor cortex. Okay, it looks like it slowed the progression by 30%. So then once you know that, I'll say, okay, so we'll put 30% as our effect size. And then you can actually use a statistical software to predict how many people you need based on the variation you expect in your population, which has to do with their inclusion exclusion criteria, which is why you'll see that some of the trials are moving towards, well, we want to get the fast progressing patients. So we get some data on them for their initial few visits, they're declining quicker. And then therefore we can figure out if we introduce something that's a therapy to people who have a more aggressive form of the disease, whether or not it's working a little easier because there's a bigger change in the slope that could be there. And therefore and there's less variability. So then you can get an answer faster with fewer people involved in the research component that could then go ahead and potentially to, discovering whether or not something's effective or not faster. So the end, it doesn't have to be 100 people. It often is in that range, but there's a few parameters, and I think one of my mentors, Dr. Sadiq, would often mention, if you're going to have an ALS reversal or something that's a cure, like, for example, the example of how insulin could be used to treat diabetes. Well, as soon as you start taking insulin and your blood sugar is under control and you're feeling a lot better, I think that type of a treatment effect, it's going to be hard to miss, or hard to have that error where maybe it didn't quite come out to be statistical, but it could have been useful. I mean, that type of effect size, you don't need many people to power that a trial when you're expecting that. But we're not expecting that in all cases. And if having a 30% improvement or 50% improvement, which I think you can talk to people, but if that's meaningful, I think when you talk to a lot of patients, I think a lot of people would say that would be meaningful. Then you can design it, but you will usually need, especially if you're going to have a more inclusive design, include more people. It's just the way that the math works. And we struggle with this all the time because we don't, I'm not myself a clinical trialist, although we, refer patients to trials, and we have trials going on through the clinic that, with the leadership of Dr. Driss and Dr. Kalb that we're involved with. And so we're thinking about these, but the point is the goal is, I think, to have as few people getting the placebo or the control group. And if we can come up with things like innovative, like the platform trial that we're part of through the Healy platform trial, that's a multi-center trial where we're using the same controls, the same placebos across multiple. That means that there's like 3 people getting a treatment and to 1 control, with the possibility later on of crossing over and getting therapy. I think that the idea is that everyone hopefully participating in ALS research, is doing so partly because they're being extremely generous to say, hey, I want to be part of finding a cure or better treatment for the disease, without a guarantee that they're going to benefit. But it is frustrating that that not everyone gets an active treatment right away. Right. And I know that from being on the other side of it, thinking about it for family members who are thinking about research about how hard it must be to accept the fact that you're not sure what you're getting while you're in it.
Yeah, and that's really helpful.
Yeah, so that is so the N, but the N of 10 is almost never the right answer, but it also kind of depends.
Thank you. Thanks for expanding upon that. And then the last question is, do you need a subscription to a service to view the latest issued ALS research papers? Yeah, so well, there's lots of ALS research papers that are out there along the spectrum, from things that are, in cells or in zebrafish and so forth, to things that are in clinical trials. Now, there's an initiative, but it requires a lot of funding in order to do, where you would make your papers, even if it goes to a subscription-based journal, open access right away. And so, but it often costs thousands of dollars of money. So depending on people's situation and who paid for the research, sometimes it's required that you have to make it open access by the people funding it. So you just need to set the money aside. But it is, yeah, it is hard to get access to some of the scientific papers, and we're trying to do a better job of that. But and I do try to myself make a lot of my publications open access as well. Not necessarily an open access journal. There's some journals where everything that they publish is open access, but it's just, you pay that journal, that's their model. But the certainly if you go to like the New England Journal or some of these journals that may have a fee if you download the article, but if you pay them enough money, they'll just make it available. I think that is probably a good model when possible for the future. And I'm not, correct me if I'm wrong, but for the papers that come out of our center, the Les Turner Foundation tries to buy rights to share the papers for a lot of the work that's coming out of Northwestern. Yeah, I'm not 100% sure, but
yeah.
we can clarify that.
And also, if you join ResearchGate, which I have no interest in you doing that, other than the one reason I do it sometimes is to get access to other people's papers, because they can actually share it directly with you. If you ask the authors of the papers, they'll send you a copy. But it is annoying because when you're up at 11 p.m. at night and you want to read the paper because the kids are asleep and you only have time, and then you have to wait a week to get it, or you can't get it at all.
It is frustrating.
It's frustrating.
Sure. This was fantastic, Dr. Franz. We really, truly appreciate you sharing your time and your expertise with us today. And we hope to have you back again in the future. So thank you again.
Thanks.
Appreciate it.
My pleasure.
Okay. Next, I wanted to let everyone know about our next upcoming webinar, which is going to be called Nutrition Optimization in Patients with ALS. It'll be presented by Brittany Hitson and Dominique Kosk of Northwestern Medicine. So we hope you'll join us on July 29th at noon. And you can register at the alslearningseries.org, probably in the next week or so, if not already. And lastly, I want to invite you to our, please save the date for our ALS annual Les Turner Symposium on ALS, happening on November 8th. The symposium features presentations from leading ALS clinicians and researchers, such as Dr. Robert Brown, and will include members of our Lois and Salia ALS clinic at our Les Turner ALS Center at Northwestern Medicine. And lastly, a big shout out to all of you who participated today in this webinar, and certainly to Dr. Franz for sharing his time, his knowledge, his expertise. And we look forward to having you join us next month. But please, before you sign off today, if you could take a moment to fill out our webinar survey that you'll receive right after we conclude, because your feedback is so important to us and really informs future programming. So thank you, and we hope to see you again next month.